Hi, everybody. Welcome to what is now round two of Miss Urban Interviews the Expert. We're going to distance learning, and obviously I still have a lot to learn because we already went through this entire interview and I wasn't recording it. So I am Kayla Urban. I am a teacher at Loudoun County High School. I teach high school biology, and this interview is with Dr. Christina Adams Waldorf, and she is a specialist at the University of Washington. I'll let you introduce yourself, but she's also my aunt. And so I've asked her, and she's so kindly agreed to come on here and answer some of the questions that my students have about COVID-19 because she is researching the SARS-CoV-2 virus in her biosafety level 3 lab. Is that correct?
Yes.
Right.
So I am an obstetrician, which means that I deliver babies and take care of women. And I'm also an infectious disease researcher. And so I like to study infectious diseases in pregnancy. And so I've spent the last 20 years doing that, studying both the effects of viruses and bacteria on pregnancies and on the health of pregnant women and on the health outcomes of their newborns, and as well as the impact on the function of the placenta.
Wow, your job is absolutely fascinating as a mother of two. I have a special place in my heart for OBGYNs. But one of my students' first questions was whether or not hand sanitizer is truly effective on fighting the coronavirus.
Hand sanitizer works, but you have to use it for almost 20 seconds. And when we are taking care of patients with COVID-19, we actually have a trained person who watches us, both putting on our personal protective equipment and taking off our personal protective equipment to avoid contaminating ourselves and cutting corners. And one of the things that they're watching for is that we're using hand sanitizer for 20 seconds. Not for 10, not for 3, for a full 20.
Wow, so that is like, you've got to, I guess, have a lot of it, very, very wet hands with that hand sanitizer instead of just a tiny bit like I see happen all the time in my classrooms and then wipe on your jeans. I don't think that is as effective as you think it is.
No, your hands need to be wet for the full 20 seconds as well.
Okay, thank you. So another question that I had from a student was, at what age is COVID deadly?
So we have heard reports of deaths in every age group, including in newborns, teenagers, and people in their 20s, although it is very, very rare. And so we think that certain health conditions can put people more at risk. The highest risk group is people that are over 50, 60, and the risk increases with increasing age, but it also increases with diabetes, high blood pressure, and heart disease, and things like that. So those are the main risk groups, but no one is really truly immune, so to speak. 15% of people between the ages of 20 and 40 can be hospitalized with a moderate to severe COVID-19 pneumonia. So it's serious in every age group, I would say.
Wow. I know you are working with the virus specifically in a biosafety level 3 lab, and your focus is on pregnancy. Can you tell me what you have found so far about how COVID-19 impacts women at every stage of pregnancy?
Right now, we still don't know very much. I mean, this is a brand new virus that has just come. Getting approval to work with the virus, getting all the lab personnel trained to work in the biosafety level 3 laboratory is a big deal. It takes a long time. There are a lot of regulatory hurdles that we have to clear even when we're investigating pregnant women, doing human studies, or even looking into medical charts to make sure that people's rights and medical rights are protected. So we have kind of cleared most of those hurdles, and the work really needs to get started, but we don't have dedicated money for this, right? I didn't write grants a year ago asking to work on COVID-19 and SARS-CoV-2, so we've put in grants and we're waiting to hear from the government, the National Institutes of Health, the Centers for Disease Control, to see if they are ready to send us money so that we can kind of get to work. So we're doing kind of what we can with startup funds, but we really need dedicated grant funding to go further.
Do you think that, what are some of the questions that you have once you get those approvals and get in the lab that you want to specifically dig into with your research as to how this is impacting women during pregnancy or the fetus itself?
Yeah, so one of the really basic questions if we start talking about the public health of pregnant women in the United States is, how sick do they get in the US? What can obstetricians here expect? Are 5% hospitalized, or is it more like 25%? How many women go to the intensive care unit? Is it 10%? Is it 20%? Or is it more like 3%? How often do we see complications in pregnancy that we need to be ready for, like preterm birth or stillbirth? How quickly do we need to go to C-section when we're worried about a woman with a COVID-19 pneumonia, or can we wait for her to get better and for the outcomes to improve for her newborn as her pregnancy progresses? So there's some really basic public health questions that we need answers to right now to better take care of pregnant women in the US. In the laboratory, I'm really interested in how the virus that causes COVID-19, which we call SARS-CoV-2, whether it can infect cells in the placenta. I think it probably can, because the placenta expresses or has on its surface a protein receptor called ACE2, and ACE2 is what SARS-CoV-2 binds to. But the expression levels may not be as high as in the lung, so we think that the placenta is probably vulnerable to the virus that causes COVID-19, but we're not sure yet. We need to see, test that possibility.
In Washington State, have you seen many examples of women who were pregnant that had COVID-19, or have we seen any fetuses born with it?
It always takes a little bit longer to get to the neonatal outcomes. Right now, I'm aware of somewhere in the neighborhood of 20 to 30 women that have been infected with COVID-19. That number is growing every single week. So as of last week, we had maybe 1 or 2. This week, we have 30. Next week, I have no idea how many we're going to have. But we keep marching closer and closer to the peak of the pandemic in Seattle, which we predict to happen around April 24th. But it's different in all different parts of the country. And there's a great website that models that from the Institute for Health Metrics and Evaluation through the University of Washington. And I can give you that link to send out to your students.
Perfect. Thank you very much.
Yeah.
I know that New York has just changed their rule from allowing nobody in the room with pregnant women when they're giving birth to allowing one person. What do you think the implications are of this rule as the benefits and the drawbacks?
Right. So we're in a public health crisis right now in certain parts of the country. New York being one of them, Los Angeles kind of moving towards that, and other parts of the country are a little bit farther behind in terms of their peak. We are not quite in a public health crisis here in Seattle. And when I use that word, I'm talking about healthcare systems that are completely overwhelmed. And when you have an overwhelmed healthcare system, your standard of care goes out the window. You can't provide the standard of care that you normally would. What happened in New York, which was reported in a scientific article last week, was that 2 women came in for delivery. They had no symptoms. They delivered, and after their delivery, they suddenly began to have shortness of breath, a cough and a fever, and they were tested and they were positive, they exposed each 10 to 12 healthcare personnel to COVID-19. What that means is that all of those people need to be quarantined, and you lose 10 to 12 healthcare providers from your pool to take care of other people. And so the concern was we can't lose all of our healthcare providers that can deliver a baby and take care of pregnant women. And it was a move to try to protect the healthcare system from completely collapsing. Here in Washington State, at the University of Washington, we are allowing the partner and one more labor support person, but no more. And now we're also allowing our hospital employees to wear a mask all day long, which will also help in this asymptomatic transmission cycle that we're really worried about. It's not ideal. Pregnant women need their labor support partners. This is crucial. There's a lot of good studies that women do so much better when they have someone to support them in labor. It's unfortunate that our healthcare systems are in crisis. Yes, yes, you need that person. But when healthcare systems are in crisis, the standard of care goes a little bit out the window, and hopefully New York can return to normalcy very soon. They're going to have a very narrow, intense peak to their COVID-19 infections because they didn't have very strong public health response in the beginning.
We had spoken briefly the first time when I wasn't recording about a mother's lung capacity during third trimester of pregnancy and what kind of implications that might have with the SARS-CoV-2 infection causing the pneumonia and the reduced lung capacity, and the woman still being in kind of a state of reduced lung capacity herself. Can you talk just a little bit more about that and what some of the concerns might be there, and the state of women, I guess, in that third trimester of pregnancy?
Sure. Sure. So if I start with the example of influenza, pregnant women in their late second trimester and third trimester are incredibly vulnerable to an influenza viral infection. And pregnant women can be hospitalized, they can go to the intensive care unit. They are the group that have the highest priority from the World Health Organization for vaccinations. When you have a brand new strain and you have a limited number of vaccines, pregnant women and children should get those vaccines first, because they're the ones that are going to die first, in addition to older people. Part of that is how the virus works. In the third trimester now, getting back to lung function, you do have a decreased lung capacity. Pregnant women need to breathe more rapidly than non-pregnant women. They're blowing off their carbon dioxide. And what that allows is for the baby's carbon dioxide that builds up in its body to diffuse into the mother's bloodstream. And then the mother blows out that carbon dioxide with her rapid respiratory rate. When you have someone who has pneumonia, they also have a rapid respiratory rate, but it's because they can't oxygenate themselves. So they're doing the best they can to move more air and oxygen across their lungs because their oxygen kind of transfusion capacity is so diminished. In pregnancy, a woman is already breathing more quickly. She can't really do it that much more quickly without becoming really impaired. But the question is, why haven't we heard about pregnant women in their third trimester dying? Why haven't we heard about lots of these cases out of China or out of Italy? Are they protected in some way from this virus than we would expect from a pathogenic influenza infection? These are super interesting questions that we're going to need to figure out really quick.
I have heard in some studies that I've read that men are impacted by COVID-19 more severely than women seem to be. Do you think that that could have something to do with the fact that women are give birth or can?
It's a great question. And I think that you're sort of on the right track. And without divulging entirely kind of the way that my research is going, I'm very interested in this question. One thing that we've learned some things from a cousin to SARS-CoV-2. And that's the virus that caused kind of a similar outbreak of really severe lung injury in 2002 and 2003. And it's called SARS-CoV. It's like almost like the parent. It's kind of a cousin. But with this virus, the
Is that
people
the
that lived,
SARS in
what?
China? Was that the one that caused the SARS in China, SARS-CoV-1? Or
Yes, it also, SARS-CoV-1, it caused it in China and then it spread to certain parts of the world like Toronto. So very similar in some ways, but SARS-CoV, when it impacts the lung and people that have studied immune responses in the lung in animal models, you can separate out who lives and who dies by the type of immune response that a certain cell in the lung makes called a macrophage. And macrophages can make more of an inflammatory immune response, or they can make more of a protective immune response. So a question for me is, are the macrophages in women a little bit more primed to go into that protective immune response? And can it have something to do with their hormones? This would be very different than influenza, but this may just be how it works with SARS-CoV-2.
you spent a lot of time before this pandemic studying a different virus, Zika, when we had the outbreak where it was causing, I guess, the microcephaly in fetuses. So, and then, okay, and for my students, microcephaly, micro means small, and cephaly means like brain or head, and their heads don't develop fully, and they're born with these very small heads. So would you talk a little bit about that research and how or if it has any implications for what we're going to be doing with COVID?
Yeah, so I've been studying Zika virus now for about 4 years. It's a very different virus, but it's also a virus that's made up of ribonucleic acid, or RNA. And all of the viruses that cause big pandemics like this, they're all RNA viruses. And the problem with RNA viruses is that they mutate very quickly. So you get new sequences very frequently. Even if you put SARS-CoV-2 into cells in a petri dish, what comes out is going to be a little bit different than what you put in, which is a bit of a problem in science. But when you have viruses that mutate that quickly, that's when you can get pandemics. So now if we go back to Zika virus, I kind of got a little bit off track. So it's similar in that way in its actual sort of biochemical makeup, in that it's an RNA virus. But it's very different in that it's transmitted by mosquitoes. And you need a certain type of mosquito. And that mosquito is super prevalent in South America, Mexico, the Caribbean, Florida, and the entire Gulf Coast. But it really doesn't spread any further north in the US than that. So we were always worried about an outbreak in Florida or the Gulf Coast because someone that had a Zika virus infection in South America got on a plane, stepped off the plane in Florida, and was bitten by a new mosquito in Florida. And then that mosquito then went and could bite someone else, and so forth. So with Zika, it was always a mosquito problem. With COVID-19, it's a human problem. And we can't control mosquitoes, but we're almost even worse at controlling ourselves, I think.
Yeah.
So the transmission from COVID-19, it's more infectious than influenza. Not as infectious as measles, thank goodness, because that would be really terrible. With measles, it can stay infectious in the air for 2 hours after someone has left the room. So that's why they shut down Disneyland and places like that when someone with measles has been at the park. But SARS-CoV-2 is for sure worse than influenza, both in its outcomes and in how infectious it is. And it's different than Zika in that it's an entire world problem. If you're talking about human to human spread, there's no geographic area where you're really safe, which I think all Americans can believe now, that it's come to the US and spread to so many cities.
We have seen, I know that you're in Washington State, I am in Virginia, but we have seen different responses and different speeds of responses through different states in the United States. And I think Washington was one that had a fairly strong response at the beginning because they got hit so hard. Can you talk about what are some of the differences between the state of Washington's response and some other areas, and what implications you think that might have on kind of slowing the spread?
Sure. We don't really know which state the virus really came to first. We just know that we detected it first here in Washington State. And we did so because we already had a pretty cool public health surveillance system in place for people who were sick. So in Seattle, we have a very large study ongoing called the Seattle Flu Study. And it's an investigators interested in studying the spread of influenza in Seattle. And lots of people signed up. And when you get sick, someone sends a kit to your house, you swab yourself, you use a little test kit, and it tells you within a few minutes whether or not you might have flu. You send back your stuff, and they do some more stuff in the lab, and then they figure out by the mutations how influenza is spreading in a big city, by zip codes, by people, by addresses, by work locations. So incredibly comprehensive, super cool. When this started going on, they said, hey, let's just check in January. Let's check to see if any.
Oh, you're frozen.
When they found a couple people,
Oh,
the computational modelers started doing some modeling, and they estimated that probably 500 people in the Seattle region were infected with COVID-19. We just didn't know it. And when they came out with that, that was front page news. And immediately companies started responding. Microsoft, Google, Facebook, Amazon, everybody shut their doors, said work from home. Within a week, private schools started doing the same thing. There was a lot of public health education here supported by the Gates Foundation to educate people why people should stay home, why this was so dangerous, what it would mean to quarantine the entire Seattle and greater Washington region, how we could preserve our healthcare systems and flatten out this peak of cases and make it more like this, so that we could preserve our healthcare systems, take care of these people, have fewer people die, and not run out of personal protective equipment. And also give us time, buy us time to get a vaccine. So that was the goal. They did it. It's impressive to see the whole plan in action. Washington State has one of the best public health systems in the country. And even so, they came out right away and said, we're not prepared. We might want to have one of the best systems, but we're nowhere near prepared for this. No one can be prepared for this. And we listened, more or less, I hope.
yeah.
We'll see.
And as we keep going, yes, for a moment there, you froze on my screen when you were talking about them taking the rapid flu test to, and then I guess I'm assuming testing all of those people that had sent those in and seeing if COVID was presenting for those people. Can you just go over that, just that one piece one more time? Because
Sure. So we had this really, really cool study that was trying to figure out how influenza is actually spread in a community. And so lots of people in Seattle know about this. When you get sick, you log into their website, they send you a kit. You find out within a few minutes whether or not you might have flu using a research test kit that they're trialing. You send back your information and you log into the website and they tell you whether or not you have influenza, which is great. And they started testing some of these samples they were getting for SARS-CoV-2 sequences in January, and they found a few people. And once they did, we knew that things were spreading in Seattle silently. Unfortunately, it then hit a nursing home, and I think we've had at least 37 deaths from that nursing home by itself. So that also put Seattle on the front page for this epidemic here in the US.
Well, I'm going to ask you two more questions. One is, how do you think that going through all of this, how we could benefit as humanity, as a population, not necessarily saying that this isn't going to be hard or horrible for anybody, but what are some of the positives, changes you think will happen within society?
Okay, well, if we're going to look on the bright side, which we need to do every day as we kind of get through this with all of the anxiety and fear and all of that, let's look on the bright side for a moment. I hope that people will travel less, at least for business. All of the meetings that we can accomplish without traveling, we can decrease air traffic. And when we do that, it's going to be better for the planet. It's one of the biggest sources of greenhouse gases. So that's item one. Item two, I hope that the good parts of humanity really shine through. The generosity that I've seen in the community, by business partners, and by just really, my entire family and community that I've seen, people really come together, try to support frontline health workers and people trying to work to stop this pandemic. So I think that those would probably be two of the best things. Personally, I became interested in infectious disease because of the HIV pandemic. When I was growing up, HIV was a virus or a mysterious condition that no one really knew what it was. And when I was in college, they had discovered that it was a virus, and everyone was trying to figure out how it worked and what we needed to do to make a vaccine. As I know now, making a vaccine has been an incredibly frustrating experience for the scientific community. HIV is such a smart virus, it's unbelievable. For SARS-CoV-2, we have much higher hopes, and there are many vaccine candidates that are currently in the works, and we hope to have one within a year. There's some really interesting vaccine designs that are new and modern, where your own body would actually become the vaccine factory. And that happens when you're using an modified RNA vaccine.
And I have seen some generosity as well in the fact that Elon Musk, the owner of Tesla, delivered over 50,000 masks to your house. Can you tell me a little bit about what that was like to have? I guess that's
yeah, it was a strange experience. I didn't realize that I was just, 2 steps away from Elon Musk. And I have to be totally honest. If you asked me who was the face of Tesla, I really couldn't have told you before this weekend. But I have a friend in UCLA, someone I've known for a long time. She's a doctor, and she wrote me an email and said there is a donor who wants to donate N95 masks. These are the masks that will filter out viral particles, and they're really critical for frontline healthcare workers. And with personal protective equipment shortages, it's key to have these. And she said, I've got a donor who wants to donate a large number of masks, but they're on the dock, they need an address. I said, what are you talking about? I called her. She said, my brother is the right-hand person for Elon Musk from Tesla. They're donating N95 masks all over the place. It's fine. It's my brother. So within a minute, I get an email from her brother saying, standing by for an address. We are ready to ship. And I don't know the University of Washington supply chain loading dock address. I've never sent a package there personally. University of Washington's an enormous place. I wouldn't have any idea where to start. I gave them my home address, and they wrote back and said the truck is leaving in 1 hour. And I started furiously typing emails to everyone I knew in leadership at the university. And within an hour, they said that supply trucks from the University of Washington would be coming to my home simultaneously. We couldn't divert the shipment. We didn't want anything different, to kind of mess things up. And they delivered the trucks at noon, the shipment at noon. We unloaded the boxes, my family did, into my garage. And then the boxes stayed in my garage for about 2 minutes, then they got loaded into the University of Washington supply trucks. All the while, we had TV camera crews and the Seattle Times videoing us and interviewing us. So it became a media circus in my garage that I wasn't expecting within about 18 hours after I got that call. So
One of my students wanted to grow up and do what you do for a living and study diseases or help with pregnancy or just be a doctor or researcher. What do you recommend
yeah,
they do?
yeah, great question. First of all, follow your heart and follow, kind of your inner compass. Stay in school. And that path doesn't have to be totally straight line. So do what you need to do to stay engaged with school and keep going. And don't listen to anyone who says that you can't do what you want to do. Be persistent and follow your heart. Go to college. College is a great experience because in college you get all kinds of doors opened up to you about things that you might want to do, and then check back in with your heart to make sure that what you're doing is really following that inner compass and what you really want to do. Because when you're doing something that is a great match for your personality, then it's never like you're really working. You're just doing what you were meant to do. In college, I found that love with microbiology. I just love how bacteria, viruses, parasites, you name it, how they can take over a cell to do what they want to do, how they cause disease, and more importantly, how to figure out weaknesses in that system that you can target with either medications, therapies, or vaccines. I love all of it. And so I kind of combined that with my kind of natural affinity to taking care of women and pregnant women and my love for pregnancy, and it just became a career. Never could I have planned this back in high school. But the HIV pandemic really helped because that really got me interested in infectious disease.
Thank you so much for your time, especially since we had to do it a second time. I appreciate you. Please stay safe through all of
Yes.
this. And again, just from the bottom of my heart and from my students, we all are very grateful. Thank you for this.
Stay safe, everyone, and take care of each other. Stay home, respect the quarantine, do your very, very best. Take care of your family, promote good information on the internet, and and learn about infectious disease. Yeah, it's a great place to be.
Thank you. Bye.
Okay, bye.